On September 11th, 2001, our youngest child, Peter, was attending a conference at Windows on the World. When the terrorist struck, he was 25 years old when he died. To honor his memory, we opted to treat people who had experienced mass violence in the form of terrorism, genocide, ethnic cleansing, civil war, and the like, and survived it, but were unable to lead their lives because of the invisible wounds of war, that is, traumatic depression and PTSD. For the past dozen years, we have partnered with governments to create mental health systems in countries in Southeast Asia and Sub-Saharan Africa. We are currently treating about 20,000 new patients per year, and I don't have very much time to tell you things, so what I'm going to do is do three things. Give you two things that we do that I think are really cool, and then present an illustrative case. Thing one, post-conflict poor countries have very fragile health systems. They are overloaded, and they don't serve the populations well, but their mental health component is virtually non-existent. And to show this to you is if you divide in Sub-Saharan Africa the burden of mental ill health, that is the number of people that need care, and you divide that by the total time of mental health professionals, doctors, nurses, social workers, counselors, etc., it turns out that each person who needs mental health care gets about 20 seconds per year, okay? Now, this is profound. This is the treatment gap, and it's profound, because what it means is increase it tenfold, and the people that need care are going to get 3 minutes per year. So obviously, that's not the way to go, all right? It turns out, fortunately, that not everybody needs everything, and that indeed most people do not need a mental health professional. And that's remarkable. We started a program several years ago of low-intensity stress reduction characterized by psychoeducation and relaxation techniques, and administering this to groups of 12 to 15 people. Here we disaggregated them by gender. This is typically in a village outside of a health center. The facilitator is a psychologist, a BA in psychology, and is, you can see the group. Here's a close-up of these ladies. We've found excellent results, and we published the results of a randomized controlled trial in the March issue of Lancet. Now, we're presently engaged in a study to shift from the professional, low-level professional, to a trained, supervised group of lay community health workers, okay? This means, if it works, and we think it will, and we see it is succeeding, that neighbors will be treating neighbors. This is the way to start to approach the treatment gap. The program is funded by WHO, UNHCR, and DFID, and we partner with Johns Hopkins and the Ministry of Health of Uganda. So that's thing one. Thing two. In northern Uganda, by the age of 2, 40% of children are lost due to mental or physical stunting. You can't bring them back, all right? You can't restore function in children that have undergone this. At the same time, concomitantly, oh, sorry, let me go back with the results. Here is 375 cases that got the therapy. The red and green lines decreasing at month 3 and 6 are PTSD and depression, and the blue line is function, a concomitant increase in function. Okay, so as I said, 40% of children are lost due to mental or physical stunting, and we can't bring them back. At the same time, women of childbearing age in northern Uganda, 40% of them have moderate to severe depression. This is a lady outside her home. Our social worker is visiting. I mean, just look at it. It's not subtle. Here's another lady. Please note, this lady is absent. Okay, she's not engaged with her child at all. The child is looking at her. She can't look at the child. Women in post-conflict countries get hit with a double whammy. First, they are subject to war and its attendant horrors, losing family, having children kidnapped, being raped, being traumatized, being physically abused. But then they return to a bitter peace with grinding poverty, with gender-based violence. And should they become depressed, they'll be stigmatized. Last year, with a grant from Johns Hopkins, we launched a program to systematically treat maternal depression and to gauge the growth and development of the child. Starting in the second trimester of pregnancy, we started evaluating and treating mothers. And then we watched the children to their second year. There is strong data from poor countries that when you successfully treat depression in moms, you get better babies, less premature births, higher birth weights, better nutrition in the early years, better attachment, better parenting, better completion of vaccination schedules, and the like. These are called dyads. You look at the mother, or you treat the mother, and you gauge the child. And this gives us objective evidence of whether or not we're succeeding. We're halfway through our pilot study, and things are looking very good. And we plan within the next year to roll out the therapy to our 4 clinics in northern Uganda, treating about 4,000 women and their children per year. Here is a picture of this. The lady in the background is the mom, and this is her mom. They've returned to function, and gardening, taking care of the family's garden is an aspect of this. Here's another lady. Here are some moms waiting for therapy for group with their newborn babies. So that's thing 2. Now let me give you a case presentation, if I may. I will present to you Henry, 23-year-old male, living in the outskirts of Mombasa, Kenya, in a settlement in a hut next to his parents. Henry's 23, he is married, his parents live next door. Henry was well until last year, when he began to have episodes of falling down and having some kind of alteration in consciousness and drooling. It wasn't, the seizures were not epileptiform. I mean, he didn't lose consciousness, they weren't tonic-clonic, he didn't have post-ictal confusion, what have you, but they were annoying. And at this time, Henry began to hear voices. So both his wife and his family, his parents, were concerned, and they took him to see a spiritual healer. And the spiritual healer diagnosed fits and frothing, because after all, Henry, fell down and had a fit, and he salivated and he frothed. And the spiritual healer said, well, Henry's got a demon, and we will work on this. And he did for several weeks, but they didn't get very far. And so the family, being kind of dissatisfied, went elsewhere, and they went to a traditional healer. And the traditional healer said, I agree with the diagnosis, it is indeed fits and frothing, but it's due to a spell that her family, that his wife's family put on him. They bewitched him because they never liked him anyway and didn't want them to marry. So they began to work together, and Henry started to improve. But he developed one more set of symptoms, and that was insomnia. And with the insomnia, he would wander at night, and he'd wander into people's homes, and that was a dangerous situation that concerned his family. So they brought him to us at the government clinic, and Henry was a schizophrenic, and we put him on risperidone, and 3 weeks later, they returned, very grateful because Henry was sleeping at night, and everything was fine, and we said to them, well, you know, can we continue to see him? Can we help him? And they said, no, thank you very much. They were very appreciative and very, very kind to us. But you've told us he has something you can't cure. Okay? The traditional healer, he can cure him. So what are the lessons here? Well, one, culture trumps everything. All right? If it isn't culturally appropriate, it'll never be scientifically appropriate. And secondly, in terms of outcome, what do you think about the outcome? I'll tell you what I think. I think it's great. What is the standard of care for SMI, for serious mental illness? Medication, to which the patient adheres, and psychotherapy. Well, traditional healers have been doing psychotherapy, talk therapy on people for generations, and they're experts. And with that, I'll leave you. These are the kids we want. And this is the future we're hoping to see. Thank you very much.